Hi, I'm Dr. Tim Kaczynski from Michigan, and today we're going to demonstrate some wonderful surgical procedures on our volunteering patient here. We have a patient that has some decayed dentition that requires extraction, so we're going to be removing teeth number 18 through 30. These are non-restorable teeth. My plan is to place 4 dental implants immediately following the surgical extractions. Now our patient's a little apprehensive today, so we have her on nitrous, but she seems to be fairly comfortable at this juncture. And we're going to use some very wonderful tools, and I call them magic. I've been using them for several years now, and I don't know if I would want to practice without them anymore. And they're referred to as the Physics Forceps. Physics Forceps come in 4 basic shapes and sizes, although there are other sizes for the third molar areas. But we have a upper left forceps. Now we're doing mandibular teeth today, so we won't be using the upper left forceps today. We have an upper anterior forceps. We have an upper right designed Physics Forceps. So here we're using the lower universal mandibular Physics Forceps, and we'll start with the anterior teeth and then we'll move to the posterior. Oftentimes with multi-rooted teeth like mandibular molar teeth or maxillary molar teeth, we're going to want to section those roots and take them out as individual roots, and it makes it a little bit easier. Sometimes we're able to take them out in pieces, and maybe we'll try to demonstrate both techniques. So let's start here. And we're videotaping. I'm going to try to start with an anterior one. And what I'm doing is the Physics Forceps has, let's see if we can get it into the film, has a beak, which is this tip here. And that will engage the lingual or palatal surface of the tooth. We have a bumper area, which will engage the labial or facial surface as deep down the vestibule towards the mucogingival line as possible. This is a leverage instrument, and we'll try to demonstrate my hand position. You're not using a lot of force in extracting. This is not a typical extraction forceps. I know they call them Physics Forceps, but it's more of a leverage tool that allows us to elevate the teeth right out of the socket. It may take a minute or two for the hyaluronidase to build up into the root structure, but then you'll see the tooth really pop right out of the socket. So let's do an anterior one first to demonstrate. And our patient knows if anything I do bothers her, she's just going to go ahead and raise her hand. So what I'm demonstrating is I have the beak of the Physics Forceps engaged on the lingual surface of the root. I have the bumper engaged on the facial surface deep into the vestibule. There's not a lot of room here. And I'm really holding this forceps with 2 fingers. And if you could just scan back a little bit, Kristen, that would be wonderful. And just to show my hands and how I'm really holding it with a thumb and 1 finger. And this is just a leverage finger. And what I'm doing is simply rotating my wrist. No arm pressure at all, no bicep pressure at all. I'm just rotating my wrist towards the facial. Rotating my wrist towards the facial. I'm not using this like a typical forceps, so there's no force here. Okay, you can get back close up there. And I'm rotating, and now it may take a minute. Now that's a long time for a dentist. I'm going to have you turn your head just a little bit towards Marina. There you go. And you can see the tooth, and I'm just rotating my wrist, rotating my wrist. Got to take your time here. Can you lift your chin up just a little bit for me? Just give me a little more room there. Not really putting a lot of pressure at all. Now I felt the tooth. You can see it starting to move a little bit. It's coming. It's coming. Lift your chin up just a hair for me. Beautiful. And that tooth just elevated right out of the socket. Now granted, this is an anterior tooth, and what's the big deal? It is a big deal. There's not a lot of tooth structure there in some of these teeth, and you can see there was no physical force at all with my hands or my arms. It really is magic, and it's something that I truly appreciate as a tool in the office. Are we doing okay? Fantastic. One done. We'll keep moving here. Now let's do the other anterior one. Same thing, engaging the beak onto the lingual surface, engaging the bumper onto the vestibule, really just holding it with 2 fingers and rotating my wrist towards the facial. I'm doing this a little bit quicker. You can kind of feel the teeth giving a little bit. Chin up for me, please. And wow, it just popped right out at me, didn't it? Nice long rooted tooth. There we go. You can't get any simpler than that. 2 down. We'll do the other one. And these teeth are pretty decayed, as you'll see from the radiograph. And chin up for me. Good. And just rotating my wrists. Rotating my wrist, and chin up for me. Chin up. Wow. Just popped right out of the socket, didn't it? Fantastic. Now, oftentimes I will have a little instrument available, a little forceps just to grab things, and my assistant obviously has a forceps available just to grab it. But you see how it just jumped right out of the socket. So we've taken out 3 teeth so far, and what I'm going to do is, because we're going to graft this site with some tricalcium phosphate material, because we are doing implants, we're going to harvest a little bit of blood. And what I did was I'm just taking a little insulin syringe without a needle, going into the socket, and just harvesting a little bit of the blood from those sockets. And then what we have is some tricalcium phosphate crystals. See if I can get it on this side a little bit clearer. Little crystals, and then we're taking the blood and just simply loading it into those crystals, and we'll harvest some more in a little bit. So we're mixing these tricalcium phosphate crystals with the patient's own blood. So with these other badly broken down teeth, we're going to take out the cuspid next. Oftentimes, it's very, very helpful to flatten the lingual surface of the tooth that you're going to extract. The beak, as we've demonstrated, the beak is flat. You can see that pretty clearly on that view. So teeth are often elliptical in shape or concave in convex in shape, and not often, but sometimes it'll slip off. So what I'll often do is just take a surgical burr, a diamond, whatever you want, and flatten the lingual surface of the tooth subgingival, maybe 2 or 3 millimeters, 4 millimeters, just to give us a purchase point of where we want things to be. So here I'm just taking a surgical burr, a carbide, 557 surgical burr, and I'm going to come up and if you retract the tongue a little bit, come back here on the lingual, and I'm just going to remove, just flatten that surface a little bit. And sometimes that just makes our job a little bit easier. So we're coming back to the cuspid tooth, engaging the lingual surface of the tooth with the beak, and engaging, chin up for me please, chin up a little bit more, and putting the bumper on the facial vestibule area down by the mucogingival junction. And chin up for me a little bit. And simply rotating my wrist slowly. And it may take a minute or two. And just you just have to take your time. It's not a typical forceps that you're using force with. It is very atypical, and you're using leverage to remove the tooth. So taking a minute or two for a dentist is oftentimes very difficult, but if you take your time, we don't break any buccal bone or facial bone, and the teeth will come out really nice. Preserving these sockets is critical for implant dentistry. Chin up again for me, please. Our patients are often just amazed how simple these extractions go. I've been practicing for a long time, and I can't tell you how many times I've heard of the patient tell me that the doctor put their knee on their chest, but I've never seen that. But those days are gone. Again, I'm just using two fingers, or a finger and a thumb, really. And if you could lift your chin up for me. Good. Now I can feel it giving a little bit, so this is a real good close-up shot. Remember, this is a cuspid tooth, long root, very, very decayed, and pop. Wow, amazing. That's a long-rooted tooth that was very badly decayed. The buccal plate is perfectly intact. Okay, let's go to the bicuspid tooth. We'll finish this side and then go to the other side. Same difference. And again, you may want to flatten the chin up for me, please. There. You may want to flatten the lingual surface. There you go, just like that. So you saw it was badly decayed. I couldn't get a good purchase point. What a great teaching example. And we'll go ahead and you can see this tooth is broken below the gum line. And we're going to flatten the surface a little bit, just to get a purchase point subgingival. Not a big deal. And now I'm getting just a little bit deeper purchase point. We're doing this without light also, so it's a little bit tougher. Chin up for me, please. Thank you. And I'm holding the beak down just to get that leverage because this tooth is so badly decayed subgingival. And we'll be able to see if we can get this using the Physics Forceps. And again, I'm just taking my time, only rotating my wrist. There is no arm pressure at all. Again, this is a very, very, very badly decayed tooth. Just broken down at the gum line, well below the gum line. I don't know if we can see that or not, but I have that forceps, please. It's as bad as it gets. Just taking my little forceps here, it's kind of broken off in little pieces here, but the tooth is definitely mobile. Just getting a purchase point on this very, very broken down, decayed, rotted out tooth. Can you suction in there, please? Good. Great. There's a little piece. All right. You can see the tooth is loose. I'm just taking a periosteal elevator and it lifted right out because the Physics Forceps did loosen the tooth. I couldn't get a purchase point off of that rooted tooth. So this is a great teaching example of reality in dentistry. All right, we have one more to do over here, and we have a molar that's a little bit difficult to see. Chin down for me a little bit. And molars, mandibular molars are two rooted. So what I'm going to do is I'm going to section it at the furcation area, and then we're going to go ahead and take it out as if it were two bicuspid teeth. We're going to take the molar tooth out now, and we'll try, oftentimes as I said we would section it. This is really rotted, but I'm going to see if I can get it out. It's a very badly infected tooth. If I can get a purchase point there. Let's see if we can get this bad boy out. Again, just using very, very little finger pressure. And actually, the furcation is separated anyways without me doing anything. It just popped right out at me. And there's the molar root. Fantastic. Now we'll go to the other side. How's our patient doing? Okay? Good. All righty. We have another lateral incisor to take out, just like we did before. Now, our patient told us beforehand that anesthesia doesn't hold on her very well. So I'm gonna try to do this one with my left hand, not to show off, but just so that we can demonstrate. I'm a right-handed dentist, by the way, not ambidextrous at all. And just using wrist rotation, really no pressure. That tooth just popped at me and just popped right out. And just to demonstrate, so I don't use my fingers. It's a long tooth that came out in a matter of seconds without a lot of effort. All right, now we have that cuspid again, so I'm going to go ahead and flatten it. And then we have a bicuspid that's super, super subgingivally, subgingivally decayed. So I'm just flattening that surface. And I'm going to go over here and do this one. And then the molar, I'm going to do the same thing. And then we have a second molar here. We'll do the same thing. Okay, we'll pull that out. So now we're going to take out the cuspid tooth on the other side, and I flattened it on the lingual. Gave the patient a little more anesthetic. And again, I'm going to use my left hand here. I'm not a left-handed dentist, but I'm just trying to establish a purchase point, and that flattened beak retains really well on that flattened surface of the cuspid. And I'm just rotating my wrist. Really, I'm just using a thumb and a finger. Now again, it may take a minute or two for the fibers to be disintegrated, so you can't rush. If you rush, that's where you could possibly have some bone damage. But if you take your time, we really don't see fracture of the labial plate or facial plate of bone. The one problem that I feel that some doctors make is that they try to use this as a normal forceps and put a lot of pressure onto it, and that just doesn't make sense. It's not engineered to do that. Just slowly rotating my wrist. And that tooth just popped. And you can see it coming out of the socket. It's magic. It truly is a magical procedure. Let me have that little forceps there. Again, I'm trying to do this with the left hand to demonstrate so my hands don't get in the way. It's a little bit more difficult for me. I have a little periotome. No. The tissue is just engaged a little bit on here, so I'm just going to help it out a little bit. Okay. I'm going to try to take this crown off. We have one tooth that has a crown that has divergent roots, and just to demonstrate, I'm going to see if we can get it out in one piece. If we can't, then what I'll do is I'll physically cut the crown off and section it. And again, I'm going to have to use my left hand to demonstrate. So I'm getting as far down on the lingual as possible, putting the bumper as far down the vestibule as possible. Now this tooth is not periodontally involved at all. And I'm holding two fingers, or a finger and a thumb, and rotating my wrist. Now this may take a minute or two or three. Now the patients really don't experience a lot of discomfort with this procedure. Most patients are pretty amazed. They may feel a little pressure, but nothing like a forceps extraction or even elevation. The important thing is to take your time and think about the technique, take a course, make sure you understand the protocol for the process, and don't skip any of the steps. For those doctors who don't do a lot of extractions in their practice for fear, bad experiences in the past, I think this is a wonderful tool to use. Again, learn how to use it correctly, and your patients will really appreciate your efforts. Chin up for me again. again, I'm using my left hand. Being a right-handed dentist, a little bit trickier. Okay, so we've given it a couple minutes probably, and certainly we could continue. I wanted to demonstrate this procedure, but let's assume that we don't feel comfortable taking the tooth out as we are right now. So what we're going to do is we're going to stop, and I'm going to take that crown off. I'm simply going to take the crown off, and then we'll section the roots and take it out as two bicuspids. And just a normal sectioning technique. And sectioning the, just taking the crown off. So what I decided to do, the teeth were fairly divergent on this molar tooth. So what we decided to do was to simply remove the crown. I'm going to section the first molar tooth, make it into two bicuspid teeth, and take them out separately. You could retract a little bit. Here, I can do that, and if you could hold the lip out. Use my fingers here, just sectioning. Okay, so we're going to come back. I section the root, and we're going to, again, I'm using my left hand here. I apologize. Try to grab onto the purchase point of the mesial root. And we got it. And I'm just holding it with my thumb. Try to retract a little bit so you can see. And we'll see if that's a little bit easier to remove. And just rotating my wrist. Chin up for me, please. Okay. And you saw me jump a little bit here. So I have the molar, we sectioned it, and if you move your chin up for me a little bit, and it may take a little time. Chin up for me again. I can feel it giving a little bit. Chin up again a little bit. You see that root? Came right out. That is magic. That's a long molar tooth. Was not periodontally involved at all. Amazing. All right. Taking out the bicuspid. Really decayed. Oh, just jumped out at me. Everybody see that? You see that tooth just laying there? And very subgingival decay on that tooth. So we did all our extractions under video conditions. We took our time to demonstrate the different areas of the mouth. I think it went really well. What I'll do now is just take a gauze and squeeze everything. Pretty smooth surface. And now I'm going to go ahead and place my dental implants and graft the other sockets. So now that we have our extraction sites complete, I'm going to go ahead and place 4 dental implants for a mandibular retained overdenture. Now I'm evaluating the bone. I'm going to try to do this flapless today. We do have good sockets, and you would think you would want to do 22 and 27 areas, but those teeth were so badly broken down that I think we're going to go into the 21 and 23 areas, and then probably 25 and 28 with our OCO dental implants. These will be the Engage implants. We'll use 12 millimeter implants, and then on 28 I think I'll use a 10 millimeter implant to stay away from that mandibular nerve. Now we did a lot of our diagnosing using the CT scan. We did an ICAT scan of the patient preoperatively, so we could virtually determine the size, shape, and position of the implants that we want to use preoperatively. So we're virtually placing the implant in the patient before we ever touch the patient, which is pretty remarkable today. The OCO dental implant is a fairly simple implant to use. We have a pilot drill, and they also include sleeves with this. You can see this little sleeve can come on and off, which will determine the proper depth. Now the Engage implant is a bone level implant, so we're going to place it as we normally would at the crest of the ridge, or as possible. So let's put a 12 millimeter, 3.7 by 12 millimeter OCO Engage implant in the number 23 area. I know we have a wonderful socket here, socket area to work with, so I'm not overly concerned with that. I have good buccal bone, and we're trying to establish position. Go ahead and suction there for me, Marina. Now this is a very sharp burr to depth, really as simple as that. Now with the system, the only burr that is end cutting is the pilot drill. The rest of the burrs are just widening burrs, and they will stop at the correct position. And it just stops. We can then go to the next diameter, which would be for a 3/7. And there's also these O-rings you can place on it to help you align the implant in the correct position. And I'm just following the angulation. Simple as that. And here we're going to open up a 3.2 by 12 length Engage implant. They come packaged sterile. What's nice about the system is the healing abutment is engaged into the top cap of the implant. We can then take the implant to site using the cap, and I'm just very carefully engaging the bone and twisting a little bit. And then this cap just snaps right off. So you can see the implant isn't fully engaged at the correct depth yet, but we'll do that with our torque driver. We have a driver with this system, a torque wrench, that has markings on it that will allow us to determine the correct tightness. So what we'll do is engage the torque wrench into the implant. You can hand tighten it if you want a little bit more. And when you hand tighten, I'll use my left hand here, you're only going to get, for a man, about 13 Newton centimeters. So we're going to go ahead and use a torque wrench in the right direction. And we are torquing the implant in position. I'm watching the implant go into the tissue. Can you suction, please? And if you want, you can stop and take a radiograph periodically. And we'll see where we are as far as depth. And what I'd like to do is probably take a radiograph at this point to see the position of the implant. And then we'll parallel the other 3 implants to this first implant. So we have one implant in the correct position, and what I did for parallelism is just place the torque wrench inside there. You can see it's in nice position. And we're going to go ahead and place our second one parallel to this, and then the third and fourth one parallel to those. OCO does have paralleling pins that you can use once you make your initial osteotomy, and I'll demonstrate that shortly. We like to spread our implants out as much as possible when we're doing a mandibular overdenture to give as much stability, as long as there's enough bone to allow this, and certainly we do. And as I mentioned, we had the number 22 area had some significant defect there, so I'm going to go back into the number 21 area, the first bicuspid area, and place our second implant. So I'm having my staff help me out here a little bit so that we can parallel where we're going. And just engaging the bone. Very sharp burrs. Same technique. Remember, we said this is not end cutting, it's just widening the osteotomy site. Let's see if we can demonstrate the little paralleling pin here. This might not be a good one to demonstrate. And we'll go ahead and place our second implant in that site. Hand tighten. Little plastic piece snaps out. And we'll simply torque the implant to final seat. Now, with the Engage being it as an aggressive implant as it is, my rule of thumb is if we can place the implant at about 35 Newton centimeters of torque, then we could load that implant. Obviously, this is an overdenture. The patient's not wearing an appliance, so it doesn't really matter. But in a tooth position or an edentulous space, whether or not we can immediately load or want to immediately load the implant will determine the amount of torque that we place the implant in at. The OCO system is unique in that it does allow incredible torque. I've torqued some of their implants in up to 70, 75 Newton centimeters, and I feel very comfortable loading those implants. Obviously, we don't want any excursive contacts, nothing that would impinge on the temporary restoration, but it is an ideal implant, as we will show you in some of our demonstrations, of immediately loading. So our second implant is in. We'll put 2 more in, and then we'll come back. So we have our 4 implants in position now, and we're going to put in healing abutments. Now again, our patient doesn't have a lower denture, but this will penetrate through the tissue about 2 millimeters since we did a flapless procedure. And suction point, please. Good. Up. And again, I'll go to my left hand. And we're just tightening that down. And I'll torque these into position afterwards. Okay, our 4 implants are in. Can you have a mirror there, Marina? Can you hold that up there? No, the big mirror, photographic mirror. And we'll kind of show it off the 2 cameras. So we have our 4 implants with our 2 millimeter tall healing abutments. And what I'm going to do next is, because I just hand tighten them, the tongue is a wonderful, strong piece of tissue, muscle, and I'm just going to torque these down a little bit so that they won't rotate out. Now this is called a one-stage procedure in that we're placing the implant and putting a taller cover screw into the site, and these will be locked in so we don't have to worry about anything coming loose over time. I changed my plan a little bit because the teeth were so infected and the tissue, the patient was relatively uncomfortable. She had told me ahead of time that anesthesia doesn't last a long time. So what I'm going to do is, we had a big infection in the 2 molar areas. I'm going to go ahead and graft those with beta-tricalcium phosphate material. We showed you how to pipette up the blood using an insulin syringe, and I just mixed it with the material. We're going to place it, and then I'll put a barrier on top and a resorbable barrier, and then we'll suture, and then we'll be finished for today on the lower. So I'm going to graft the infected molar areas, and we have our grafting material mixed with blood, and I'm just going to take my instrument and harvest. And blood is good in the site, and we're just packing gently in the area. Packing gently in the area. Now I'm not crushing the product. If I could have a gauze, please. And I'm just going to kind of squeeze down with finger pressure. I don't know if we can see that or not, the bone particles in the site. Now tissue does grow 10 times faster than bone, so what we have to do is we do have to put a little bit of a barrier And it's a collagen barrier. And I'm just kind of moving the material around. And I'll tell the patient, these are like little granules of sand almost, and it coagulates pretty fast. But if they do notice some crunchies afterwards, it's not going to hurt. It is a salt that will not harm them if they swallow it. But sometimes little particles do escape, which isn't a big problem. And we pre-cut a piece of barrier, a collagen barrier. We'll put it to site. Resting it on the facial and the lingual surface. Give it another squeeze to kind of close that site up. Instrument, please. And we can see the barrier in place. And I'll just do a cross-stitch suture to hold it in place. If you don't, we have some here too.
Yeah, I don't know how much space.
We have them. We have them.
Oh, yeah.
We have them here. If you need it. Nope. Last stitch. Okay, I'm going to numb the top.
Or call 1-877-9physicsforceps.com or call 1-877-987-2284.